Welcome back, everybody. Ready to dive into something a little unusual today. We're tackling Brucella.
A fascinating bug, really.
Oh, absolutely. And I think it's a particularly interesting one for us as medical microbiologists.
Yeah, definitely. Lots of unique challenges there.
For sure. And to guide our deep dive today, we'll be pulling from Gillespie and Hockey's Principles and Practice of Clinical Bacteriology.
Great text. Always so comprehensive.
It really is.
Oh.
Okay, so Brucella, what makes this bug so special? What's got us all buzzing about it today?
Well, for me, the history is just so interesting. We actually knew about Brucella as a human pathogen way before we knew about its impact on animals. Imagine that.
It's like it was hiding in plain sight.
Right, causing all this trouble, and we didn't even know where it was coming from.
So we had Malta fever plaguing people.
Yeah, exactly. Jeffrey Allen Marston described the human illness.
And then later on, in 1886, David Bruce isolates Brucella melitensis. And that was kind of the smoking gun, wasn't it?
It was. But even then, the mystery wasn't over. I mean, the Mediterranean Fever Commission spent years. Years. From 1904 to 1907, meticulously tracing this outbreak back to its source.
Okay, so spill the beans. What was it?
Goat's milk?
Goat's milk. Wow. Talk about a got milk problem.
I know, right?
But wait, there's more, right? It's not just B. melitensis causing a ruckus.
Oh, no. We've got a whole crew of Brucella species out there, each with their preferred animal host. So there's B. abortus in cattle, B. sus hanging out with the pigs.
And B. canis, man's best friend's not-so-friendly bacteria.
Exactly. And we can't forget Alice Evans. She really deserves a lot of credit for connecting the dots between these seemingly different bugs.
Leading to that aha moment, and ultimately the genus being named Brucella.
That's right.
Okay, so we've got this bacteria, it's got a history, it's causing trouble in all sorts of animals.
Yeah.
But what is Brucella? Like, under the microscope, what are we dealing with here?
Well, it's pretty unassuming at first glance. Just a tiny gram-negative coccobacillus.
No frills, huh?
Nope. No fancy capsule, no endospores, no native plasmids to speak of.
So it's a minimalist kind of bug?
You could say that. But don't let that fool you. Brucella's straightforward structure is actually a big part of its success story. I mean, look at its cell wall, a total marvel of efficiency.
Okay, I'm intrigued. Tell me more about this efficient cell wall.
Well, first you have that tough peptidoglycan layer that gives it structural integrity. But then on the outside, we've got lipopolysaccharide, or LPS for short. That's a key player in Brucella's pathogenicity.
Ah, LPS, always causing trouble. But classifying Brucella itself, I've heard that can be a bit of a headache.
It can be.
Yeah.
Currently, we've got 7 nomen species that we recognize, and each of those has its own set of biovar. Those are like subtypes within a species. But the interesting thing is,
What's that?
well, despite all these variations, when you look at the DNA, they're incredibly closely related, maybe even a single species.
Wow, a single species causing all this commotion. That's pretty wild.
It is. And it might even have ties to soil-dwelling bacteria, if you can believe that.
Really? That's fascinating. So this seemingly super specialized pathogen might have roots in a much broader microbial world.
That's the thinking.
I love it when seemingly unrelated things turn out to be connected. Now let's talk about genetics for a moment. Brucella has this unusual 2-chromosome structure. But then some species are like, nah, we're good with just 1 big chromosome. What's the deal with those genetic variations?
Well, that's a question that's keeping researchers busy. It seems these differences might explain some of the variations we see in Brucella. You know, the different characteristics, different ways the disease presents itself.
Ah, so like different models of a car. Same brand, but with unique features, different performance capabilities.
Exactly. And when it comes to actually causing disease, Brucella's LPS plays a starring role, specifically the O antigen.
Right, with its A and M epitopes.
Yeah, exactly. Those are crucial for helping us differentiate between the different Brucella species and also for understanding why some infections hit harder than others.
We also have to watch out for that cross-reactivity.
Oh, for sure. That shared C epitope can trip us up sometimes.
Yeah, leading to those false positives in some of our diagnostic tests. Always got to be on the lookout for that.
Absolutely. It's all about careful interpretation of the results, right?
Right. Now, I've heard whispers about Brucella's lipid A. Something about it being a little unusual.
It is. Compared to your typical endotoxin, Brucella's lipid A is a bit of a stealth ninja. It's modified in a way that makes it less potent at triggering certain immune responses.
So it's like Brucella's trying to slip past our immune system's radar undetected.
Exactly.
So we've got this bacteria. It's got a fascinating history. It's a master of disguise with this sneaky endotoxin, and it's got this unique genetic makeup. But how does it actually cause disease? Let's get down to the nitty-gritty. How does Brucella pull off its pathogenic magic trick?
Well, one of the most remarkable things about Brucella is its ability to survive and even thrive inside our very own cells, specifically macrophages.
You mean those cells that are supposed to be our immune system warriors engulfing and destroying invaders?
The very same. But Brucella's got a whole bag of tricks to turn those macrophages into its personal hideouts.
Okay, I'm officially creeped out. But tell me more. How does Brucella pull off this cellular invasion?
Well, first, it's got to avoid getting eaten in the first place, right? So Brucella's evolved ways to resist phagocytosis, that process where macrophages engulf and try to destroy bacteria.
So it's like Brucella's wearing a suit of armor, making it hard for the macrophage to grab hold of?
Yeah, something like that. But let's say a macrophage does manage to engulf Brucella. The fight's not over. Brucella can actually prevent the fusion of lysosomes.
You mean the cellular garbage disposals?
Those are the ones. It prevents those lysosomes from fusing with the phagosomes, the vesicles that contain the engulfed bacteria.
So it's basically disarming the macrophage's weapon system.
You got it.
Huh.
And on top of all that, Brucella produces enzymes that can neutralize those reactive oxygen species, or ROS.
Ah, those ROS. We've talked about those before, like little cellular grenades.
Precisely. But Brucella's got the tools to diffuse those grenades, rendering them harmless.
So it's like Brucella has built a multi-layered defense system, making it incredibly difficult to eliminate.
Exactly. And all of this helps explain how Brucella establishes those chronic infections, often persisting in tissues like the spleen, the liver, and the bone marrow.
Talk about a tough opponent. But our bodies aren't just sitting ducks, are they? What about our own defenses? How does our immune system fight back against this wily Brucella?
Well, our immune system has got two main branches that come into play here. We've got the innate immune response and the acquired immune response, and both are important in the fight against Brucella.
Okay, so let's start with the basics. What about those initial barriers?
Well, intact skin is your first line of defense.
Makes sense.
It acts as a physical barrier, preventing Brucella from entering the body. So basic hygiene, things like hand washing and proper wound care. Crucial, especially for those working with animals or handling potentially contaminated materials.
Always good advice. But what about when those barriers fail?
Right. Well, then stomach acid, step up to the plate.
So that acidic environment helps kill off any ingested bacteria.
Exactly. But anything that reduces stomach acidity can actually increase a person's susceptibility to infection. So things like antacids or some medications, things to keep in mind.
Interesting. Okay, so what about our more specialized defenses? How do our neutrophils handle Brucella?
Well, they do their best. They engulf and try to destroy those Brucellas. But different Brucella species have different levels of susceptibility, and some are better at evading them than others. We also have a complement system, a bunch of proteins that can tag those Brucella for destruction. It's like putting a bullseye on their back for phagocytes to target.
So it's a multi-pronged attack.
Exactly. But while the innate immune system is busy mounting its initial defense, the acquired immune response is getting ready to launch its own counteroffensive. And this involves humoral and cellular responses, both essential for controlling Brucella.
Okay, let's start with humoral immunity. What's happening on that front?
Humoral immunity is all about the antibodies. Those are produced by B cells, and they're like guided missiles targeting specific invaders. In the case of Brucella, we see IgM antibodies showing up first, followed by IgG antibodies.
And those antibodies can either neutralize Brucella directly or tag them for destruction by other immune cells.
Exactly. But antibodies alone aren't enough to conquer the sneaky bacterium. That's where cellular immunity, those T cells we talked about earlier, come into play.
Right, those T cells, the conductors of the immune orchestra.
That's a great way to put it. And one of the key things T cells do is activate macrophages, making them better Brucella killers. And a key signal in that activation process, interferon gamma, or IFN.
Ah, yes, IFN, our old friend. Like that megaphone we talked about before, amplifying the immune response.
It is. IFN boosts the macrophage's ability to produce those reactive oxygen species and nitric oxide, both highly toxic to Brucella.
So it's like those macrophage grenades we were talking about earlier. Now they get an extra kick, making them even more effective.
Precisely. And IFN day also activates other immune cells, like natural killer cells.
Those are the ones that can directly target and destroy infected cells, right?
Right. So it's a team effort, a multi-pronged attack involving various components of the immune system all working together to eliminate Brucella.
Exactly. And remember, the immune response is a dynamic process. The outcome of this microscopic battle depends on many factors. Things like the host's overall immune status, the specific Brucella species we're dealing with, and the way that Brucella got into the body in the first place.
That's like a game of chess, isn't it? Brucella makes a move, our immune system counterattacks. It's fascinating, but also a little terrifying when you think about it. But let's shift gears for a moment and talk about the global spread of this bug.
Brucellosis is a zoonotic disease.
Meaning it can jump from animals to humans.
Right, and it's a global problem, though we do see higher prevalence in certain regions, particularly those bordering the Mediterranean Sea, the Arabian Peninsula, the Indian subcontinent, parts of Mexico, Central and South America. So this isn't just something for people working in agriculture or living in developing countries to worry about.
Not at all. With globalization and international travel, anyone can potentially be exposed to Brucella. And underreporting is a real issue, especially in regions like sub-Saharan Africa. So the true burden of brucellosis could be much higher than we currently realize.
And to bring this closer to home, think about the U.S.-Mexico border. We've seen cases there linked to unpasteurized dairy products.
Oh yeah, definitely. It highlights how something as seemingly simple as food choices can have big implications for disease transmission, globalization, and food practices. It's all connected.
It is. Okay, so we've got these different Brucella species where they're different animal hosts. Does that variation impact human risk? I mean, are some species more likely to cause trouble than others?
Well, certain occupations and lifestyles definitely carry a higher risk.
Okay.
Anyone working closely with animals like ranchers, veterinarians, abattoir workers, they're more likely to encounter Brucella. Hunters, especially those who target feral swine, need to be aware of the risk too.
It all comes down to understanding the potential sources of infection and taking appropriate precautions. But here's something I've always found interesting. Human-to-human transmission of brucellosis is incredibly rare.
That's right. Unlike many other infectious diseases, brucellosis doesn't spread easily from person to person, which is good news, right? And get this, there's even some evidence suggesting that people with AIDS might actually have some degree of protection against brucellosis, though the reasons behind that are still a bit of a mystery.
Wow. Really? That's wild. It really speaks to how complex the relationship between Brucella and the human immune system is. Okay, so we've covered the organism, we've talked about its pathogenicity, its global spread, and even touched on some of the immune responses. But let's get down to the clinical nitty-gritty. How does this infection actually show up in patients? What does brucellosis actually look like?
Well, that's one of the tricky things about brucellosis. It can be a real chameleon. It can mimic all sorts of other illnesses.
So it's trying to fly under the radar.
Exactly. And the way it starts can vary, too. Sometimes it's acute, a sudden high fever. But sometimes it's more insidious, vague symptoms that develop slowly over time.
So you could easily mistake it for something else. What are some of the common symptoms that should make us think, maybe this could be brucellosis?
Well, as we mentioned, fever is pretty common. Often comes with chills, sweats, muscle aches, fatigue, just feeling blah. Some folks get headaches, back pain, joint pain.
Okay, so those are pretty general symptoms. Anything specific to brucellosis that might help us distinguish it?
One thing to look for is the pattern of the fever. It often goes up and down in a cyclical pattern, high in the evenings and lower in the mornings, kind of like a roller coaster for your body temperature.
So that undulating pattern can be a clue.
It can be, but brucellosis doesn't just cause general symptoms. It can affect multiple organ systems and lead to some serious complications.
What kind of complications are we talking about?
Well, one of the most common is osteoarticular involvement. Brucella likes to target the spine and large weight-bearing joints.
So it's not just a passing fever. It can actually cause long-term problems if it's not treated properly.
That's right. And neurobrucellosis, though it's less common, can occur too. That can lead to things like meningitis, encephalitis, or even peripheral neuropathy. Serious stuff that needs aggressive treatment.
Okay, definitely sounds like we need to take brucellosis seriously. What about the heart? I know some bacterial infections can cause endocarditis.
You're right. Endocarditis is a potential complication of brucellosis. It's rare, but it can be life-threatening if it affects the heart valves.
So this is a bug that can really pack a punch if it's not caught and treated early.
Exactly, and that's why prompt diagnosis is so important.
Speaking of diagnosis, let's transition into the lab. This is where you medical microbiologists really shine. So how do we pin down a brucellosis diagnosis?
The gold standard is isolating the bacteria, getting it from a clinical specimen. Blood, bone marrow, cerebrospinal fluid, even tissue biopsies.
Sounds straightforward enough.
Well, there's a catch. Brucella is a notoriously slow grower.
How slow are we talking?
We might need to incubate those cultures for weeks before we see anything.
Weeks. That's a long time to wait, especially when you suspect a serious infection.
It is, and it can be a real challenge. But thankfully, we have some other tools in our arsenal.
Like what?
Serological tests.
Mm-hmm.
These can be really helpful when we need to make a quicker assessment or while those cultures are incubating.
Right. Antibody tests. So we're looking for those antibodies against Brucella in the patient's serum.
Exactly. And one of the classic tests we use is the serum agglutination test, the SAT.
Ah, the SAT. Tried and true, right.
It is. It's relatively simple, pretty widely available. It basically works by mixing the patient's serum with a suspension of Brucella antigens.
Okay, and what happens if the patient does have those antibodies against Brucella?
If the antibodies are there, they bind to the antigens, causing the bacteria to clump together. Agglutination. It's visible to the naked eye.
Simple but effective. But what about false positives? Can other things cause agglutination in the SAT?
They can. Sometimes we see false positives, particularly if the patient has antibodies against other bacteria that happen to cross-react with those Brucella antigens. So we have to be aware of that possibility.
So we need to be cautious about interpretation.
Always. It's not a foolproof test, but it can be a really valuable piece of the puzzle.
Now, are there other tests, maybe more specific tests, that can help us get a clearer picture?
We do have other options. One is the 2-mercaptoethanol agglutination test, or 2-ME-SAT.
What's special about that one?
It helps us differentiate between the IgM and IgG antibodies.
So we can tell if it's a recent infection or a more chronic one.
Exactly.
That's really helpful.
It is. And then we've got ELISA, enzyme-linked immunosorbent assay. That one can be even more sensitive than the SAT, meaning it can pick up those antibodies even when they're present in very low amounts.
Sounds great. So why don't we just use ELISA all the time?
Well, there's a downside. The lack of standardization across labs can make it tough to compare results.
So it's a trade-off. We gain sensitivity, but we lose some of that standardization that makes comparing results between labs so easy.
It is a trade-off. Ultimately, the choice of which test to use depends on a lot of factors. What stage of the infection we suspect, what resources are available, the overall clinical picture. Sometimes we even use a combination of tests to get the most complete picture.
It's like you're piecing together a puzzle, right? Using every clue you can get from the patient's history, their physical exam, and all those lab tests to arrive at the right diagnosis.
That's a great way to put it. And once we've got that diagnosis, the next step is figuring out the best way to treat this infection.
And we'll be tackling treatment and everything that goes along with it after a short break. So stay tuned.
You know what always gets me about Brucella? Its ability to just hang on inside the host. Even with the immune system doing its best to kick it out, it's really quite impressive.
It's like a microscopic David going up against the Goliath of our immune defenses. And somehow, Brucella manages to hold its own. It's wild. But how does it actually do that? How does it survive inside those cellular fortresses, the very cells designed to destroy it?
Well, Brucella's got this whole arsenal of strategies it uses. One of its main tactics is actually interfering with phagocytosis. That's the process where one of our immune cells, like a macrophage, engulfs a bacterium, right?
Yeah.
So it traps it inside this little membrane-bound compartment called a phagosome.
So it's like the macrophage is trying to put Brucella in solitary confinement?
Exactly, but Brucella doesn't give up that easily. It's got ways of disrupting the signaling pathways inside that macrophage, so the phagosome never gets to mature into a phagolysosome.
Now remind me, what exactly is a phagolysosome, and why is that fusion so important?
A phagolysosome forms when a phagosome fuses with a lysosome. Lysosomes are basically sacs of powerful enzymes. They break down and destroy things. Foreign invaders like bacteria. It's like the macrophage's recycling center.
Got it. So by blocking this fusion, Brucella is basically preventing the macrophage from activating its waste disposal system.
That's exactly it. It creates a safe haven for itself within the very cell that's trying to kill it.
That's pretty sneaky.
It is. Brucella's turning the tables, turning the macrophage into a Trojan horse, and that's how it manages to persist inside the host and even replicate.
So interfering with phagosome maturation, that's one of Brucella's tricks. What else does it do to evade our immune system?
Well, it also produces enzymes that neutralize those reactive oxygen species, those ROS we talked about earlier.
Right, those little cellular grenades that our immune cells use to attack.
Exactly. Brucella's got a way to diffuse those grenades, rendering them harmless. It's almost like it's wearing a suit of armor, protecting itself from all of our immune system's attacks.
So it's disarmed the macrophage's garbage disposal, and now it's put on a bulletproof vest. This bacteria is really prepared.
It is, and there's another fascinating layer to its strategy. It can actually manipulate the host cell's machinery to its advantage.
Manipulate? How does it do that?
Well, it can actually hijack the host cell's protein synthesis pathways, forcing the cell to produce proteins that are beneficial for its survival. Kind of like taking over the control panel of a factory and reprogramming it to make what you need.
Wow. So Brucella is not just hiding out in our cells, it's turning them into its own personal factories.
That's one way to think about it. It's incredible how pathogens have evolved these mechanisms to exploit their hosts for survival.
It really is remarkable, if a little unsettling. And it explains why these infections can be so persistent and difficult to treat.
Absolutely. But the good news is, our bodies have ways to fight back.
Let's talk about those countermeasures. What are the key players in our defense against Brucella?
Well, even though they can be manipulated, macrophages are still a critical part of the defense. They're on the front lines, engulfing and trying to destroy the bacteria. They're those first responders trying to contain the situation.
But we know Brucella can outsmart macrophages. What else do we have?
Remember, macrophages don't work alone. They're part of a complex network of immune cells that all communicate with each other. T cells, for instance. They play a vital role in activating those macrophages, making them more effective at killing Brucella.
So the T cells are like the generals directing the macrophage troops.
That's a great analogy. And one of their main weapons is a signaling molecule called interferon gamma, IFN. Remember we talked about that earlier?
Right, that megaphone, amplifying the immune response.
That's it. IFN boosts the macrophage's ability to produce reactive oxygen species and nitric oxide. Both of those are very toxic to Brucella.
So it's like giving those macrophage grenades an extra boost to make them more effective.
Exactly. And IFN also activates other immune cells, like natural killer cells.
Those are the ones that can directly destroy infected cells, right?
Yep. So you see, it's this multifaceted attack. Multiple immune cells working together, coordinating their efforts to try and get rid of this Brucella.
It's a full-blown immune system assault.
It is. But remember, Brucella is not going down without a fight. It's persistent. The outcome of this battle depends on a lot of things. How strong the host's immune system is, which specific Brucella species is involved, even how the infection happened in the first place.
It's a microscopic game of chess, isn't it? With moves and countermoves on both sides. Fascinating. But let's shift gears for a bit and talk about the clinical side of things. How does this infection actually show up in patients? What does brucellosis actually look like?
That's a really important question for medical microbiologists. Brucellosis is notorious for mimicking other illnesses. Doctors call it the great imitator.
So it's like it's trying to hide in plain sight.
Exactly. The way it starts can vary too. Sometimes it's acute, sudden high fever. Other times it's more insidious, just vague flu-like symptoms that develop slowly over time.
So it could easily be mistaken for a bad case of the flu. What are some of the common symptoms that should make us consider brucellosis?
Well, fever is a big one. As we said, that's really common. And it often comes with chills, sweats, muscle aches, fatigue, loss of appetite. Some people experience headaches, back pain, joint pain as well.
Okay, but those symptoms alone, they're not really specific to brucellosis, are they? What else might point us in the right direction?
One clue is the pattern of the fever. It often rises and falls in a cyclical way. High in the evenings, lower in the mornings.
That's the undulating pattern we talked about earlier.
That's it. That can be a bit of a giveaway. But remember, brucellosis can impact more than just causing general symptoms. It can affect various organ systems, and that's where things can get more serious.
Right. We talked about complications earlier.
Exactly. And one of the most common ones we see is osteoarticular involvement. Brucella likes to target those weight-bearing joints, especially in the spine.
So it's not just a matter of riding out a fever for a few days. Untreated, this can lead to some real problems.
It can. And then there's neurobrucellosis, which can lead to meningitis, encephalitis, and even peripheral neuropathy. Those are serious complications that require aggressive treatment to prevent long-term damage.
It sounds like brucellosis is more than just a simple infection.
It is. And we can't forget about endocarditis, even though it's rare. If Brucella infects the heart valves, it can be life-threatening.
So this bug can really pack a punch.
It can, which is why it's so important to diagnose and treat it early.
Speaking of diagnoses, let's head back to the lab. How do we definitively identify a brucellosis infection?
The gold standard for diagnosis is isolating the bacteria from a clinical specimen. That could be blood, bone marrow, cerebrospinal fluid, even tissue biopsies, depending on where we think the infection might be hiding.
Makes sense. Get a sample, grow the bacteria, and then we know for sure.
Right. But there's a wrinkle. Brucella is notoriously slow-growing.
Okay, how slow are we talking here?
We might need to incubate those cultures for weeks before we see any growth.
Weeks? That's a long time to wait, especially if someone is really sick.
It is. That's why serological tests can be so valuable. They can give us a quicker assessment while we're waiting for those cultures to grow.
Right, those antibody tests. We're looking for evidence that the body's immune system has encountered Brucella.
Exactly. And one of the most common tests we use is the serum agglutination test, or SAT.
The SAT, a classic, reliable, right?
It's a good test, relatively straightforward and widely available. We mix the patient's serum with a suspension of Brucella antigens.
Okay, and if the patient does have antibodies against Brucella?
Then those antibodies will bind to the antigens, and that causes the bacteria to clump together, which we call agglutination. You can actually see it happening with the naked eye.
So it's simple, but it works. But I'm guessing there are some limitations. What about false positives? Can other things cause that clumping?
They can. We do sometimes see false positives with the SAT, especially if a patient has antibodies against other bacteria that happen to cross-react with the Brucella antigen, so it's not a perfect test.
So we have to be mindful of that when we interpret the results.
Absolutely. Context is everything, but it's still a really useful piece of information.
Are there other serological tests that might be more specific? Tests that can help us refine our diagnosis?
We do have other options. One is the 2-mercaptoethanol agglutination test, or 2-MES8.
What's the advantage of that one?
It helps us distinguish between the IgM and IgG antibodies.
So we can get a better sense of whether the infection is recent or more long-standing?
Exactly. It helps paint a more detailed picture of what's happening.
Okay, that makes sense. What about ELISA? Enzyme-linked immunosorbent assay. Does that have a role in diagnosing brucellosis?
ELISA can be helpful. It's very sensitive, meaning it can detect even tiny amounts of those Brucella antibodies. But the problem is there's not a lot of standardization between different labs.
So it can be hard to compare results from different labs.
Exactly. So it's a trade-off. Higher sensitivity, but less consistency in how we interpret the results.
So ultimately, which test you choose depends on the situation, right?
It does. It depends on the suspected stage of infection, what resources are available, the overall clinical picture. Sometimes we'll even use a combination of tests just to make sure we're getting the most accurate information.
It's like piecing together a puzzle, right?
Yeah.
Got all these different pieces of information from the patient's history, their physical exam, the lab results, and you've got to figure out how it all fits together to make the right diagnosis.
That's a great way to think about it. And once we've got that diagnosis, we can start thinking about how best to treat the infection.
And we'll be diving into treatment and everything that comes with it right after this, so don't go away. You know, it's funny. Brucellosis, it's a big deal, a global health problem, but it doesn't get a lot of press, does it?
It's true. It's not like the flu or COVID. It doesn't have that same kind of buzz around it.
Right. But for those of us in healthcare, especially in areas where it's more common, it's definitely on our radar. So let's talk about managing these Brucella infections from a clinician's point of view. What are the things that healthcare providers really need to keep in mind when someone comes in with symptoms that could be brucellosis?
Well, first of all, we have to consider it, even if it seems unlikely, especially with patients who've traveled to areas where brucellosis is common, or if they work with animals or have had unpasteurized dairy products.
It's about connecting the dots, isn't it? Their history, the symptoms they're describing, any potential risks for exposure.
Exactly. And early diagnosis, that's key. Catching it early and starting treatment right away can really make a difference, reduce the chances of complications down the road.
And we've talked about treatment, that combination of antibiotics, doxycycline, and an aminoglycoside like streptomycin or gentamicin for at least 6 weeks. That's a long time to be on antibiotics.
It is. But we have to be thorough. Brucella is a tough bug to get rid of. 6 weeks is usually the minimum to make sure we've completely wiped it out.
And I imagine patient education is really important here, making sure they understand why they have to finish all those pills, even if they start feeling better before the 6 weeks are up.
It is. Stopping treatment early, that's a recipe for relapse. And it could even contribute to antibiotic resistance, making things even harder to treat next time.
Okay, so we've got early diagnosis, we've got the right antibiotics. What else is important when we're managing a patient with brucellosis?
Close monitoring. It's essential. We need to watch patients carefully throughout treatment, make sure they're improving, but also be on the lookout for any signs of complications.
So regular checkups, blood tests to keep an eye on liver and kidney function, maybe even imaging studies to look at specific organs if we need to.
Exactly. And we need to be particularly aware of things like endocarditis, neurobrucellosis, osteoarticular complications. Those can be really serious if we don't catch them early and treat them aggressively.
It's a bit like a chess match, isn't it? You're always trying to anticipate what Brucella might do next and be ready to counter its moves.
That's a great analogy. And alongside monitoring for complications, we also need to make sure we're providing good supportive care, helping patients manage their symptoms.
What does supportive care look like for someone with brucellosis?
Well, it depends on the severity. For most people, it's simple things. Rest, fluids, over-the-counter pain relievers to help with the fever, aches, and pains. But in more severe cases, hospitalization might be necessary. Intravenous fluids, stronger pain meds, that kind of thing.
So it's a holistic approach. Treat the infection, but also take care of the whole person. Make them as comfortable as possible while their body fights it off.
That's exactly right. It's about looking at the whole picture. So to manage brucellosis effectively, you need a multifaceted approach. The antimicrobial therapy, of course, but also supportive care, close monitoring for any complications that might crop up, and good communication with the patient throughout the whole process. It really is a team effort.
Couldn't agree more. Well, I think we've given our listeners a pretty comprehensive look at brucellosis today. From the basic microbiology all the way to the clinical challenges of diagnosis, treatment, and management.
Yeah, we've covered a lot of ground.
We have. But before we sign off, I want to leave our listeners with a few take-home messages. Just some food for thought as they go back to their labs and clinics.
Sounds good.
So, first of all, brucellosis. It might not be as flashy as some of those other infectious diseases out there, but it's a global problem. And it can have serious consequences, especially if it's not caught and treated properly.
Absolutely.
So that means early recognition is essential. We need to know the risk factors. We need to be on the lookout for those characteristic symptoms. And a high index of suspicion is never a bad thing, especially when someone's been traveling or working with animals.
Couldn't agree more. Early diagnosis and treatment, that's the best way to prevent those long-term complications.
And the lab is our partner in this fight. Culturing Brucella, that's still the gold standard. But those serological tests are invaluable. They give us those early clues while we're waiting for those slow-growing cultures to pop up.
Right. And clear communication between the lab and the clinicians, that's crucial too.
Absolutely. We have to be on the same page, working together to make sure those patients get the best possible care.
I think we've given everyone a good foundation for understanding brucellosis and the challenges it brings. But like with anything in microbiology, there's always more to learn.
Isn't that the truth? It's a constantly evolving field, and that's part of what makes it so exciting.
It is.
So to our listeners, stay curious, keep those microscopes focused, and as always, keep those lab coats clean. And until next time, happy micropunting.